I've been looking forward to this conversation and wanted to congratulate the Seattle Science Foundation for what really has been a tremendous platform and phenomenal contribution to our specialty. I've put together what I hope is an ambitious collection of thoughts over the next hour as we contemplate together the opportunities we have as a specialty to truly innovate. And here at UC San Diego, it's impossible to start any conversation around innovation without first acknowledging the tremendous creativity and talent of my faculty partners. And you'll see in a later segment of my talk why that is. It's my feeling that we are, as a specialty, at what I'd like to consider an Apollo moment for neurosurgery, in the sense that we recently celebrated the 50th centennial of the Apollo moon landing. And there are certain engineering, creative, and scientific endeavors around that effort that were extraordinarily critical to the success that we enjoy today in many different areas of material science and engineering. And so it's important, I think, as a specialty for us to contemplate how we can best contribute to the advancement and treatment of neurologic disease. So I'll walk you through essentially 6 segments of my talk. The first is we'll talk about the 4 distinct domains of surgical scientific progress. I'll share with you my perspective as an endovascular neurosurgeon on the technological practice we've made and how you actually make a determination to introduce new technology into your practice. And then we'll take a systems perspective and look at what I consider to be the necessary and sufficient conditions for innovation. And then over the last 15 years, I'll share with you my personal journey through 5 distinct neurovascular conditions, because I think they are examples of how to actually apply the principles that I'll outline. And then I'll conclude with some general comments about our ecosystem and how this bears on other areas of neurosurgery outside of cerebrovascular disease, and leave with an eye to the trainees on the call in terms of mentorship and what's required for training the next generation of surgeons. And so this is an important foundational slide for the talk, in the sense that as surgeons, we have distinct opportunities to enable a modern medical progress. We are very natural observers of the biological implications of intervention. And so a lot of the substance of this talk will look at observations of physiology and natural history. And we tend to focus on progress in surgery in terms of procedural advancements, that is, the tools of surgery, either in terms of operative technique, imaging, and visualization, or devices. You'll see in the upper left corner an inset of Halstead, who very famously removed his mother's gallbladder from the kitchen counter. And so I'm very fond of saying that you have to have a pretty strong command of anatomy in order to do an operation like that by candlelight. And so quite clearly, the way we advance as a discipline is by applying tools to new situations and engineering operations to the point that they become highly reliable for our patients. And then there's a whole separate area of health services research, which really refers to applying a population data to the care of an individual patient, or randomized trial design, which is less the substance of this talk. And then lastly, once you know the right thing to do in the care of an individual patient, how do you actually hit that mark every time? And so processes of care, systems engineering, and surgical training become extraordinarily important. And so I'd like to start with Charlie Drake, because Charlie Drake 30 years ago took on what at the time was a death sentence, a giant basilar tip aneurysm with a 2-year rupture rate of over 85% that was uniformly fatal. And so he had the benefit of a very unforgiving competing natural history. And he made some fundamental observations of physiology around flow reversal. What you'll see as we look at Charlie Drake's aneurysm is there have been iterations in device and practice adoption that actually allow us to actually treat that aneurysm in a very straightforward way today. And when I think about transformative devices, when we establish that threshold in innovation, very important to think about devices that allow you to treat a problem that you weren't able to treat before. And because of advances in material science, we're now reaching a point where we're reaching the technical limits of what's possible through engineering, and we need all the more to redouble our efforts in understanding biology, rheology, and pharmacology. And most importantly, as surgeons, our responsibility to our patients is to have a meticulous scrutiny of our complications. So Charlie Drake, management of giant basilar aneurysms. This was an original aneurysm angiogram by Alcott, showing the giant basilar aneurysm. You can see Drake's original drawing here. You can see after a Hunterian ligation, you can see the PCOMs being picked up and a complete occlusion of the aneurysm due to flow reversal over the basilar terminus. That same aneurysm today can be managed in a very technically straightforward way with the use of catheters and coils. Similarly, 15 years ago, when I trained, this was a challenging aneurysm for surgeons, large anterior circulation aneurysms at the skull base. At the time, we could occlude these regularly with coils. And the first seismic advance in endovascular was really the advent of flow diverters that were designed specifically for this case. I was personally a slow adopter on flow diversion, in no small part because I was concerned about surrendering endovascular access to the aneurysm. I was concerned about our understanding of dual antiplatelets at that time and committing that much intracranial hardware to the parent artery. This was the case that began to change my mind. And so this was a woman who came in with a giant recurrent aneurysm. She'd been shunted and treated by well-intentioned providers on the outside. There'd even been the placement of an enterprise stent. And we actually found the true lumen of that stent and deployed a flow diverter, as you see here, and saw substantial stasis in the aneurysm. But what we uncovered serendipitously at that time was the biology of what I consider the pulsatile insult, because that patient had actually come in with very poor visual acuity. And immediately after the procedure, she had a dramatic improvement of her vision to 20/30 in the left eye and 20/40 in the right eye from what had been light perception in 2400. And so this was an example of how our incomplete understanding of flow diversion at that time really gave us an opportunity to improve our treatment of diseases that we had a poor response to previously. Similarly, an important technical threshold in terms of the equipoise between endovascular open surgical treatment and what I like to call a sonic boom was the 2 millimeter artery, and having reliable self-expanding stents that could successfully protect 2 millimeter arteries. And so this was a patient with a large fusiform P2, P3 segment aneurysm, and we were able to actually use that device with very high reliability in order to treat that aneurysm endovascularly. If you apply the lessons, though, of those first two cases, you would think to yourself that there's never a role for surgery, because if endovascular techniques could actually remove a pulsatile insult, and one of the indications for surgery is a compressive lesion, then it stands to reason that a wide neck pike aneurysm like this could be treated with a 2 millimeter stent and with coils. This patient, though, with glossopharyngeal neuralgia shows that there's still important diagnostic value that comes to the surgical experience. And so you can actually see here the 7th and 8th nerve, the 9th nerve draped over the pica complex and the aneurysm here. But what you could not appreciate until at the time of surgery is there was substantial tenting down low by the V4 segment. You can see the brainstem in the depth here, and the need to mobilize the V4 segment in order to adequately decompress and treat this patient's pain. Obviously, the aneurysm was clipped at the same time as shown in this intraoperative angiogram. So I'm fond of invoking Magellan in terms of thinking about the exploration that needs to take place as part of the surgical event. And so to that end, there are times where we deal with rare diagnostic challenges. This was a 68-year-old gentleman who presented with precipitous cognitive decline with bad bilateral thalamic edema. One of my interventional partners actually shot this angiogram and astutely identified this tentorial fistula, was able to actually catheterize the fistula, but you can actually see here was occlusive, and this is not a position that would be very tolerant or safe for embolization. And so the patient was taken to surgery for a sitting craniotomy, and this is an example of how adjuncts in the operating room have actually improved our practice. You saw the intraoperative angiogram on the original image on the last case, but in a sitting position, that's not possible. And so we were able to identify that fistula and clip and occlude it, and using 4D flow, leave the operating room knowing that we had actually completely obliterated that fistula. And this was confirmed on the postoperative angiogram. I'd encouraged at the outset a meticulous scrutiny of complications. And so some of the cases where we gain the most insight are in and around those cases where we actually have regrets. And so when we think about leveraging art and science in the treatment of these lesions, this is the aneurysm that I think remains the most challenging in kind of modern neurovascular treatment, the fusiform M1 segment aneurysm. We know from good experience that this is something that can be treated with a bypass and clip occlusion. And the times where in a desire to innovate, we stray from our principles, that's where we can run into trouble. And so this was a 75-year-old woman who came in with a giant progressive aneurysm. She was aphasic and hemiparesis. This has been known to her for a long time. And there was a real question of whether her symptoms were referable to either ischemia or mass effect. And because of her age, we convinced ourselves to use telescoping flow diverters to reconstruct this giant aneurysm with a very good result until post-operative day one. That aneurysm thrombosed completely. And so that aneurysm needed to be resected. And so this patient tolerated that. She ended up being an MRS of 3. And it was quite by design that we actually resected this aneurysm en bloc, because we wanted to learn the mechanism of thrombosis and understand the biology of our intervention. And what we found was that these things tend to clot from the outside in. And it's quite clear that there is a threshold in terms of the length of your construct and diameter that would lead to this occlusive event, even through therapeutic aspirin and Plavix. And so it's really there where we find ourselves at this precipice of an intrasaccular device era. And you can see by the variety of devices demonstrated on this slide that from a technical standpoint, our engineers are really at the point where they can develop very, very reliable materials that can deploy in any number of conformations. The challenge, however, and one of the reasons there hasn't been broad adoption of intrasaccular devices, is it hasn't reduced our reliance on aspirin and Plavix. And it's really that threshold that's going to be required in order to allow a complete management of these problems through endovascular means. And so that journey through kind of the iterative advance in material science and endovascular treatment really, I think, provides a nice segue to thinking about the necessary and sufficient conditions for innovation in terms of contemplating the competing natural history and important consideration of standard of care alternatives and the unmet clinical need. And then what comes with that is all of the infrastructure in terms of the sufficient conditions. Outside of that availability, you need to have CEC and DSMB and FDA processes, which we'll go into, and obviously access to good biomedical engineers and iterative device application. And so we're fortunate at UC San Diego that our own experience has been informed by being involved in those processes over the last 10 years and involvement in cost effectiveness analyses in order to ensure that the adoption is prudent and efficient. And then lastly, once you know, as I said, the right thing to do in the care of a given patient, you need to hit that mark every time and engineer process of care in a way very similar to our colleagues in cardiology and ischemic stroke to ensure highly reliable care. And so in the next segment of my talk, I'm going to actually touch on this concept of Edisonian failure and the idea that as surgeons, we need to be empiric and recognize that we've never failed. We've really just found 10,000 ways that haven't worked. And I'll share with you my observations on 5 distinct cerebrovascular conditions to apply the principles that we just outlined. And so I'm fond of saying that we're in the penicillin era of ischemic stroke. The idea being that with IV TPA, the revascularization of large vessel occlusion was very poor. And IMS3 was an important negative trial in advancing our understanding of ischemic stroke, because while that trial wasn't successful, it did demonstrate as surgeons how technically good we needed to be. Those patients that had a TICI 2B or 3 outcome, meaning we revascularized at least half or the entire territory that was occluded, ended up having an MRS of 0 to 2. And so that suggested to us that the reason IMS3 failed is we weren't looking at the right patients, those patients with confirmed arterial occlusion, and we weren't actually getting the job done a high enough percentage of the time. And that led to applying the important technical principles of stents, which were very successful in the coronary world at solving the problem of opening arteries, and taking those best elements and using them as retrievers in order to not commit the patient to intracranial hardware. And not surprisingly, the early stent retriever trials demonstrated very clearly comparable MRS 0 to 2 rates as an IMS3 and a much higher rate of revascularization. That has led to stories like Stefan's and a avalanche of trials in the New England Journal and other prominent journals in 2015 that demonstrated dramatic benefits to intervention for anterior large vessel occlusion. And what I want you to take away from these slides is less the individual trials and more the number needed to treat in these slides for independence were anywhere from 3 to 4. And so it's not an overstatement to say that we're in the penicillin era of stroke, because that efficacy actually rivals penicillin for the treatment of sepsis. So now as interventionalists that we live in a time where we can get the artery open a high percentage of the time, it's important for us to think about the biology underlying that intervention. And Xu Chen, Daiyu, Tang, and Albert Shao have been great colleagues of mine in this iterative approach to understanding what happens to the endothelium in stroke. Because our intravascular system is not plumbing. You can see the dynamism of the endothelium in terms of static and laminar flow, and the fact that junctional proteins absolutely demonstrate a use it or lose it phenomenon. That is under pulsatile flow or organized flow, that is our native physiology. They're preserved under oscillatory or disrupted or static flow. You can see the tight junctions are actually lost. Most importantly, from a thrombectomy standpoint, if you fail to open an artery, endothelium doesn't heal if injured. If you restore pulsatile flow in 24 hours, you can see a re-endothelialization of the damaged segment. And so we used a rotational scanner to look at the degloving injury associated with the prominent thrombectomy devices at that time, and constructed these three-dimensional models for each size of the artery. We then did animal validation trials in a porcine model to look at those patterns of injury across the major devices at that time. And what we actually found is in a canine model is that the level of endothelial injury did actually dictate your overall final end organ stroke volume. So how much damage you did to the endothelium actually did matter. And in human patients, we then applied an MR sequence to stroke patients. And you can see in this 3T sequence, we were able to actually identify those vessels that had been instrumented by thrombectomy devices and the level of endothelial injury that had occurred. And so the threshold in innovation, though, is did we change care? And those observations, that sequence of work from an artificial vessel model to a porcine model to demonstrating a difference in end organ damage and then to human stroke patients, demonstrated the importance of choosing the correctly sized and thrombectomy device. And so Solitaire, the dominant device at that time, did lead to the availability of some intermediate sizes. And importantly, for Trevo at the time, the device was eccentric and tapered on one end and led to an eccentric injury. And so they went to a more flared, uniform design to minimize the endothelial footprint of the thrombectomy device. And there was ongoing work at that time in terms of neuroprotective agents. And so if we apply those same principles to the treatment of aneurysms, recall, that we're dealing now with important issues of device healing. This is a parallel plate model that allowed us to actually look at the flow stimulation for a very simple sidewall aneurysm. And with the application of a tracer, we were able to look at the measured velocity field and then compare our flow simulation to that measured tracer. When we actually moved to a physiologic pulsatile flow as opposed to constant flow, you can see that the vectors actually become much more complicated. And you can actually see that when we expand our parallel plate to a three-dimensional half-dome model. And what happens, and this has not been reported elsewhere, is we were able to successfully grow human endothelial cells within this artificial model. And not surprisingly, you could actually see a focal ulcer develop in the endothelium based on shear wall stress and pulsatile flow. Interestingly, also, you see an exuberant endothelialization at the inflow tract of the aneurysm and endothelial cell loss at the outflow tract. We further used 4T MRI to actually confirm our simulations with live MRIs of our model. And so you could actually see that we are quite far along in understanding the flow in these lesions and then being able to apply them in testing different forms of treatment. And so when we look at, for example, the application of flow diverters with varying porosity, we can actually see the implications in terms of shear wall stress simulation. And this was an actual aneurysm of a young child who we got a very successful reconstruction, but the device actually was never able to successfully heal. And so we are continuing to apply these technologies to better understand how our interventions can reconstruct these very complex problems. And so stroke is that first condition. And it's long been my view that we are at the point we were with stroke 5 years ago with intracerebral hemorrhage today. It's not lost on this group that basal ganglia hemorrhage is an extraordinary cause of morbidity and mortality. And there was really foundational work done by the MISTI ISIS group, first with MISTI 2, to demonstrate that there was some promise and signal of an improved modified Rankin with evacuation of basal ganglia hemorrhage. And this is, in my view, felt to be an important opportunity for neurosurgical innovation, because as this slide shows, as you were successful in volumetrically reducing the hemorrhage to less than 10 or between 10 and 20, the opportunity to be in the blue and yellow, meaning having a functional outcome with what otherwise is a devastating disease, was much higher. Most importantly, you're also able to reduce your length of stay and all the untoward complications that come with a long ICU stay. And so one of the challenges at that time was the MISTI procedure or the CLEAR procedure was the introduction of a catheter and the intraparenchymal or intraventricular administration of TPA. And you can actually see here the symptomatic bleeding rate with that strategy was as high as 23%, which blunted any potential therapeutic benefit. And so this was the first case ever done using, at that time, one of the first endoscopic aspiration devices, the Apollo device. And it was a 53-year-old gentleman who came in with this large basal ganglia hemorrhage. And through a supraorbital incision, we were able to begin to evacuate this clot. And you can see what's required of the surgeon is very straightforward. And it's a very controlled procedure where you have progressive evacuation of the clot. And you can see very clearly a very, very nice structural collapse of the lesion. And this was that patient, that first patient that was done post-operative day 2. He's still hemiparetic, but the EVD is out and he's on the floor. So this demonstrates the promise of this technology if you are able to achieve that volumetric reduction. And this was our extensive early experience around that. And so when MISTI 3 came out, I'm very fond of saying this was the IMS 3 trial for endoscopic evacuation of ICH, in the sense that while there was a failure of the primary clinical endpoint, again, it was because there wasn't a sufficient rate of technical success. But the MISTI investigators gave us important lessons in terms of trajectory planning and the criticality of engaging the clot along the long axis. Most importantly, they demonstrated to us as surgeons what our target needs to be. In order to achieve the clinical outcome that we want, we need to be less than 15 cc's. And most importantly, they actually explained the underlying biology for that outcome, in the sense that those patients who had a good functional outcome with clot reduction, the reason that is because they hit that threshold of a greater than 85% reduction or got to less than 15 cc's. And they did very, very impressive quantitative assessments of perilesional edema and demonstrated when you got to less than 15 cc's, you had a dramatic improvement in the reduction in perilesional edema. And so you evacuated the direct mass effect of that clot, but you also dramatically attenuated the edema if you get to less than 15 cc's. And so it's my feeling that endoscopic evacuation of ICH, and there are 2 ongoing trials now, both embolized through Medtronic and SQUID through BALT, invest on endoscopic evacuation of ICH. I think they're actually going to make that point. I preempted what I consider the humility of the mundane, and that is with SQUID and with embolize, and that is that it's long been known that the pathophysiology of chronic subdural hematomas relied on neovascularization of those membranes, and that's what led to actual recurrence. That observation led to enthusiasm for middle meningeal artery embolization for chronic subdural hematomas. And what I personally appreciated as we started to do these cases was how angiographically exuberant these membranes are if you actually get a good microcatheter selection. And so you can see here, this is a patient who'd had a previous craniotomy at an outside institution and had a recurrent chronic subdural. We embolized, and what you see very nicely here is dramatic resorption of the subdural over about a 2-week period. And so that's another example of where we're harnessing physiology to change our management of disease. One of the best examples, though, that I can think of is in the area of carotid stenosis. And carotid disease is an area where there's a collision of many different specialties, cardiology, vascular surgery, and neurosurgery. And for those historic reasons, symptomatic versus asymptomatic disease has always been characterized by a neurologic deficit in the referable vascular distribution and degree of stenosis because it was easy to measure. That's how NACIT, ACAS, all of those trials were actually organized. And the operation you're seeing here in endarterectomy is the gold standard, but it's reserved for every patient, with stenting being reserved for patients who are high risk for CEA. The approach, though, to carotid disease as it stands today has no meaningful consideration of intracranial collateral circulation or systemic blood pressure. And it was known that a subset of patients had a durable antihypertensive benefit from carotid stenting, but that effect was poorly characterized. And it's clear that our anatomy will ultimately drive our physiology. So we identified 2 groups of patients, patients who had low resistance circle of Willis collaterals, either through the ACOM or the PCOM, or those patients who had high resistance PO collaterals. And so in order to compensate for their compromised hemisphere. And we looked at 74 patients and hypothesized that those patients who had high resistance PO collaterals, if you open their carotid, those patients are going to have a durable antihypertensive benefit because they'll no longer be resistant on the high MAPs required to perfuse through PO collaterals. And that indeed proved to be the case. They were able to come off their antihypertensive medications and were living at a much lower systemic blood pressure. And so this has important implications for how we classify patients with symptomatic carotid disease. It should be patients with referable neurologic deficits or patients who are living at very high systemic MAPs to maintain perfusion to their compromised hemisphere. And we actually found baseline MAPs of 96 or higher as being highly predictive of patients who have poor intracranial collateral circulation. And this was the forerunner of an important trial, CREST-H, that's ongoing now, that's looking at precisely that question. And it's my feeling that broad observation around physiology is going to really change how we manage carotid disease in the intermediate term. That doesn't mean we're not in a place where there's still an important role for tailored treatment and artisanship. And so you can see here a patient who had presented with a watershed hit and this mobile plaque. You can see it here. And not all endarterectomies are the same. And there are times where it's important to actually remove this en bloc and actually preserve that mobile plaque in place. And so now it's my hope with my final cerebrovascular condition to actually bring it all together. We've shown you through ischemic stroke and endoscopic evacuation of ICH how to engineer procedures and iterate their design. We've talked about harnessing physiology with middle meningeal artery embolization, chronic subdural hematoma, and understanding selection criteria in carotid stenosis. But the coup de grace in vascular disease is the treatment of AVMs. And so how do we apply all those things together in the management of AVMs? And this is an area where someone who's an open cerebrovascular surgeon and interventionalist, where you can combine those skill sets, in my view, in the most seamless way. And this was a 32-year-old woman who came in, large intraparenchymal hemorrhage, obviously referable to this AVM. You can actually see, and this is what's important in terms of, in my view, dictating the timing of evacuation of surgery. Venous outflow obstruction is an important harbinger of potential instability in the AVM. And so due to extrinsic compression of the clot, you can see here on just the baseline angiogram, significant stasis in the vein.
There was additional supply from the PCA. And so very quickly, without heparin on board, we embolized three of the MCA pedicles. This was our cast and went straight up to the operating room. And I highlight these angiographic pictures because they are the only residual, and you will see those now on the video. You can see here in the lower left here, the varix. You can see we immediately take the last remaining MCA feeder. We have our embolic cast as an important guide and divide that to actually get the anterior segment. We then turn medially and decompress the clot, knowing the only feeder that's left is this PCA supply that's here. We take that and then we remove the AVM. And all that's left at that point is this is the deflated varix, and remove that. Do our ICG because we know we have everything in view, and this is the patient the next day. And this is her post-op scan showing some intraventricular blood from her original hemorrhage, but she did not require an EVD. Similarly, there are AVMs in deeper locations now with the use of navigation and operative visualization. We can treat in a more ambitious way than we treated before. This was a 20-year-old who had a deep choroidal variant AVM here that was periventricular. You can see it was actually fed from both the ACA and the PCA. Similar approach, we did 2 quick pedicles and took the patient upstairs for an interhemispheric transfalcine resection. So this was a left-sided lesion that we approached transfalcine with the right side down. And so you can see here, after the interhemispheric exposure, the mobilization of that initial vein, and then you'll see a division of the falx. You can see the illumination that we have, obviously with modern microscopy, to very precisely come down, combined with navigation on the residual supply here that's from the PCA. You see our embolic cast there. And then we'll actually open the mesial surface of the left hemisphere just above the AVM. And the advantage of the contralateral approach here is the residual supply is going to be from the choroidal. And because the ventricle is a potential space, it's very helpful as a surgeon to be able to look along the long axis of that potential space to limit potential dependent blood. And so this is the same way endovascular techniques have really changed. Our adjuncts in the operating room have allowed us to be much more controlled in the treatment of AVMs that we've been historically. And you can see here the final amputation of the vein after completely devascularizing this lesion. And it comes out very easily with a very nice control. And this is the patient's post-operative angiogram. And then the final case around AVMs, in my view, actually demonstrates the importance of interdisciplinary team. And so this is your conventional Spetzler-Martin grade 3 AVM, where it's really been informed by our new appreciation of cortical anatomy. So after multi-staged embolization, we actually begin to actually identify a plane around this AVM. And what's so instructive about this case is that there is essentially this muffin top, for lack of a better term, to the AVM, where these are arterialized veins that are actually not involved in the lesion. And so being able to distinguish this is just the peninsula of the AVM and is not involved in that anterior structure is very, very helpful. And you can see then you're able to distinguish those things that belong to the AVM and the large vein posteriorly that belongs to the brain. And so being able to do those things in kind of an informed, targeted way with use of navigation is not something that we were able to do as cleanly even 5 or 10 years ago. And so I've shown you, I hope, a progression, technical challenges notwithstanding, through endovascular material science, and shown you 5 distinct conditions where the use of surgical adjuncts and our understanding of physiology has really changed in a very short time how we approach those diseases. And a big part of the reason that is, and our opportunity is to follow OSR's guidance around innovation, that ultimately those observations are made at the patient's bedside. And so we're fortunate to have a lot in the way of that infrastructure here at UC San Diego. And as important, we have a phenomenal ecosystem of VC and biotech partners with over 650 million in biotech VC in San Diego last year. And you can see that cluster of kind of the three major ecosystems by an order of magnitude over others nationally. And we have a chancellor level engagement in order to do that. And so the next step for us as a department in our partnership with engineering is we're developing an alliance that would involve a GMP facility for a device. We are continuing to apply the animal and training infrastructure at our Center for Future Surgery and have a Center for Novel Therapeutics that is an incubator. This infrastructure is helpful when you think about the full continuum of innovation. And so a nice example of that is the 3D 4K exoscope, which came as an early prototype to UC San Diego. We did the foundational cadaver work to demonstrate comparable visualization between microscopy and the exoscope through the 5 kind of conventional intracranial approaches. And that put us in a position to do the first series of cases in people. And the reason I show this particular case of a quadriparetic woman and a foramen magnum meningioma is you can see the benefit of the exoscope in maintaining a very wide depth of focus. So you can see the vert and the depth, you can see the floating nerve roots and protect them all to get the patient a complete and safe resection. And so I'm fond of invoking the kind of the astronaut model of neurosurgery in the sense that now at the point of action, we have much in the way of tools to keep us safe. Inline tractography, we have fluorescence to guide intrinsic resection of tumors. Tractography has gone from artwork to being applied in a very real way in the operating room. And I'm also fond of emphasizing what true functional image is, that is magnetoencephalography, which allows us to use electrophysiologic stimulation to map, for example, the tibial responses in a patient with an intrinsic lesion. And so this is a case from a partner of mine, Dr. Beaumont, who actually brings us all together, a recurrent glioma. And you can see his view as he actually toggles back and forth between the fluorescence, mapping the tracks, trying to not violate the ventricle, and getting a kind of a gross total resection in a way that's incremental and safe for the patient. And so it's really using these tools all together, and you can see it's taking the contour of the involved gyrus and to get those last little bits in the depth in a way that's controlled and safe. So we've come a long way from Halstead's day. Similarly, we can use the intraoperative MRI not only to confirm our resections, but also to apply things like laser thermal energy. And with the use of tractography, can pick trajectories in a way that just flat out weren't possible 5 years ago. I already touched on the value of the MEG in terms of true functional imaging. This is essentially the median nerve response in a young skateboarder with cavernoma who presented with seizures. And so you can see we can obviously pick a trajectory, not relying on an atlas or tracks, but true functional stimulation. And so another area, recall my threshold of transformative technology relies on the ability to do things you weren't able to do before. This is a large skull-based tumor, and I'm fond of showing this video as someone who's not an endoscopic skull-based surgeon myself, because it really demonstrates in my mind how the incremental advance of a technology and a technique can really mature and put you in a position to have views that Drake never dreamed of the anterior basilar and the ventral surface of the brainstem. And so when I think in those terms, it really demonstrates to me that we as surgeons really enjoy kind of a golden age of visualization and tools to treat previously untreatable problems. And I'd be remiss to not mention that I used to think a combined case was embolizing and resecting a tumor, but there's no question that as neurosurgeons, we've been beneficiaries of advancements in the systemic treatment of cancer. And that meaning that as surgeons, we used to focus on the primary brain tumor alone. But now, because of advances in systemic cancer, metastatic disease and good intracranial control is worthwhile because we have such good immunotherapy and chemotherapy agents. And our team at UC San Diego really helps us take advantage of those advances. And so now, as we look at our own Apollo moment, this was the invocation that JFK originally gave in urging us to go to the moon. And I'm fond of emphasizing what, in my view, is an underappreciated aspect of that speech, in which he said that the goal of going to the moon would serve to organize and measure the best of our energies and skills. And so one of the real values, in my view, of developing an innovation ecosystem is that you are not limited by your own imagination of what your partners will achieve. And so my partner, Dr. Chachi, has really done foundational work in patients with chronic spinal cord injury and the iterative work of understanding, is there a role for stem cell implantation? And so you can see here, you have to first demonstrate you can get the cells there, that the cells are getting where you want them to go. This was in an animal model, demonstrating there's not the appropriate immune response, and most importantly, that these stem cells are then differentiating into the three major populations of neurons, astrocytes, and other glial products. He then took the additional step, and I must confess that until he undertook this work, I hadn't thought about the engineering that goes into and the use of a floating cannula to actually deliver those cells in an atraumatic way, and did the first in human studies here at UC San Diego. Similarly, Sharona Benheim, one of my partners in neurorestoration, has worked with Shadi Daye to take advantage of her own access to the living brain by applying research electrodes to SCG depth electrodes and working to develop better clinical contact, better contact grids, 1024 contacts versus 64. And you can see the very rich maps of cortical behavior and electrophysiology that they're able to harvest from these improved contacts. And so the advances in material science and computational power don't just apply to endovascular, they really apply to all areas of neurosurgery. And Joe Osario, outside of obviously refining our own processes to make sure that we have access to adequate imaging in the operating room to verify our instrumentation, is also really pushing the envelope of what's possible in terms of spinal column deformity. And I know that Dr. Pham has been a previous guest in discussing robotic surgery. So I'd like to close what I hope has been a helpful perspective on innovation with just a couple comments about mentorship and surgical training. I hope it's known to this group and a story for another time that William Osler, the father of American medicine, was a real mentor to Harvey Cushing. And you can see Cushing gave Osler's profile and homage with his description of the terional. Osler also was among the very first, near and dear to my own heart, to describe the tropism of aneurysms for the circle of Willis. But one thing that Osler said that to me is so critical is the idea of the spirit of a department in a university. And I'm going to read it in full because I think it's important. The successful teacher is no longer on a height pumping knowledge at high pressure into passive receptacles. When a simple, earnest spirit animates a college, there is no appreciable interval between the teacher and the taught. Both are in the same class, the one a little more advanced than the other. So animated, the student feels that he has joined a family whose honor is his honor, whose welfare is his own, and whose interest should be his first consideration. The reason I share that is it emphasizes two key things. It emphasizes the idea of urgency and ownership in our next generation of surgeons. And so we've used simulation and other things to try to actually push the envelope in what's possible. And I'll touch on who this gentleman is in a moment, but the reason he's here is because of these images. A woman who comes in extremis, large left parenchymal clot, responsible MCA aneurysm. This looks like a very dire situation involving the dominant hemisphere. And this is the moment that we're trying to prepare our trainees for. I'll confess to you that some of the videos in this talk have not been presented at real speed. They've been presented fast forward. I'm sure that was obvious. But this is a real-time video. And the reason I show this is because you can see remote from where the dissection was taking place because of the transmural pressure between the atmosphere and the mean arterial pressure. There was a spontaneous rupture of the aneurysm, and you can see the fundus of the aneurysm here extending to the neck. There had already been a dissection of the bifurcation. And so you have about a minute here because the patient's exsanguinating, all the blood that's coming out of the head should be going to the brain is going to swell, and you're going to lose your surgical corridor. And so this is the moment to have the appropriate reserve to place those two clips. And you can see very nice collapse of the dome now. And then now you have the opportunity to irrigate and confirm your clip position and that you're comfortable. So this is the moment. You can see here the M1 and both M2s there, the depth that we're trying, the deflated aneurysm in the foreground. And the reason I share this case is because this is her 10 days later. She's 3 out of 5.
You sit down.
And the reason I like this video so much is because you would expect this, and this is her post-op scan, you would expect this patient to be hemiplegic, aphasic, devastated. That's what I expected. And not only is she able to talk, but she's able to observe social decorum. And when the physical therapist asks her to sit down, she says, please. And I mean, that's a situational awareness you would not expect given that scan 10 days after surgery. And so I hope to leave you with the idea that we should not be so nihilistic in the treatment of cerebrovascular disease or presume that we understand the mysteries of prognosis. And so that's why Voltaire's admonition, in my view, is a very good one. And I do want to acknowledge one of our residents, Dan Cleary, who's developed a simulation model to try to put residents in that similar position. And what's interesting about this exercise and the work that Dan and others have done is he demonstrated that this is something that responds to training. So this is the resident's heart rate, and you can see it's well above 100 at different points in the simulation, whereas a faculty member actually maintains an appropriate response to the change, but not a dysregulated response. And so this is what we need to get at as surgeons in terms of the mastery of self and to prepare our trainees for that event. And so I hope because we are part of a small guild-like community that I've helped provide some signposts in terms of how we can make progress together as a specialty. If we are observant and committed and clear-eyed about what our own technical limitations are, and we're judicious in the application of the advances that have been made in devices, technique, and operative visualization, I think we're really living in a golden time in terms of what we can offer patients and advance our treatment of neurologic disease. But we all need to be in the arena kind of making our contributions. And so I'll stop there. I really appreciate your indulgence with the technical difficulties. I hope did some small justice to the work, and I'm happy to take any questions.
Thank you very much, Dr. Khalessi, for the great presentation. I'm sure everyone enjoyed listening to that. So for all attendees, questions can be texted in the chat, and we can present them to Dr. Khalessi. So while we're waiting for any questions, going back to ICH, the Apollo endoscopic approach you presented, would you use that for like the two cases you presented? Would you do that also for a left-sided ICH, similar size?
Yeah, a great question. A lot of that would depend on the distribution of the hemorrhage. And so if it were kind of a posterior thalamic bleed where I think the patients would be heavy paretic, but that the insula and the perisylvian structures were largely preserved, I think that's a reasonable thing to offer that patient. And it obviously matters if the patient is densely aphasic up front. But I wouldn't uniformly exclude patients with a dominant hemisphere lesion in the same way that weighs very heavily against taking patients, for example, for decompressive craniectomy in a completed stroke. And a big part of the reason that is, and I think what our responsibility is when we're offering patients prognosis, is to really look obviously at the pre-morbid exam, but also to look at areas of the brain where there's been irreversible injury to the brain. And often those structures are displaced, but they're not irreversibly injured in the case of a large hematoma.
You've touched on many vascular subjects and also non-vascular neurosurgical subjects, which was a very wide coverage of innovation potentials in neurosurgery. Would you like to say anything about the area of vasospasm?
Sure. Yeah, I can speak to that. So I think vasospasm is a very interesting area in no small part because for a long time, it's befuddled our specialty that there clearly was something distinct about aneurysmal subarachnoid hemorrhage and vasospasm associated with that, as opposed to patients who may have comparable burdens of intracranial hemorrhage, for example, in traumatic settings, that don't seem to have spasm. So I think the first thing to really emphasize is that there are clear things that increase your risk of meaningful spasm. And that is obviously having an aneurysmal subarachnoid hemorrhage. If someone has a second hemorrhage, for example, in transit or iatrogenically, those patients often have refractory spasm. There's often heralding hyponatremia with that. And in addition, young patients, because they have reactive vessels with a lot of vasomotor tone, are at much higher risk than older patients. So knowing who you need to be very vigilant about in terms of the treatment of spasm is the first initial step. The second thing that we know is that patients with large vessel spasm, meaning the basilar, the M1, or the A1, those patients tend to be very, very responsive to mechanical endovascular therapy. And so upwards of 85% of those patients will only need a single, for example, touch angioplasty at some point over their course. Patients who require intraarterial administration of medications like verapamil, for example, or any other calcium channel blocker of your choice, those tend to be very short-lived agents and are usually for more small vessel spasm. And our practice are preferentially used for MCA patients that have needed to be clipped, because those are the patients where they're likely going to have a significant sylvian burden of blood that's beyond the deep cisterns. And what we are, among others, are doing work on now is finishing or building, I should say, on the momentum of work that had been done by Brian Ho and others in looking at CSF diversion and aggressive CSF diversion, either by EVD or lumbar drain. And it's clear that 7 days of aggressive CSF diversion is extraordinarily helpful in those patients who have real refractory spasm. What I hope I've left you with is the idea that independent of your disease of choice or your subspecialty, that the principles for innovation are the same. And that really looking at baseline physiology, biology, understanding those cases where our current technical methods have failed, those are really the opportunities to innovate. And I'm excited to see what your group and the audience does to kind of further our specialty next.
Thank you very much, Dr. Khalessi. We really appreciate you being with us this morning and giving this excellent presentation, very interesting talk. Thank you very much. We hope we're going to see you once again soon, maybe in our platform. Thanks a lot, Dr. Khalessi. Thanks, everyone.
Thank you, Dr. Khalessi. Appreciate your time very much. Great talk.
Oh, my pleasure. My pleasure. Appreciate all of your patience. Take care. Have a great morning.
Thanks a lot.